crosslinking. This presentation will summarize different debates and advances in corneal collagen crosslinking practice. All of us know that corneal collagen crosslinking techniques were developed in Europe by researchers at Germany at the University of Dresden in late 1990s. They invent the conventional technique of Dresden protocol of corneal collagen crosslinking with epithelial removal. After practicing corneal collagen crosslinking for several years, refinement of the technique of corneal collagen crosslinking becomes a must for all physicians. Recent advances and debates about corneal collagen crosslinking are needed to be discussed in this presentation. What is the most recent? What is the most effective? What is the important tricks we should consider during corneal collagen crosslinking? Up to date, one of the topics we will speak about is the debate about EBon versus EBoff crosslinking. EBoff versus EBon crosslinking. One of the big questions is whether epithelium on crosslinking can provide similar result to crosslinking procedures where epithelium has been removed in EBoff crosslinking. All of us know the advantages of epithelium on crosslinking, including reduced risk of infection, less corneal haze, and fewer delays in epithelial healing. All these complications can occur in EBoff and doesn't occur in EBon. However, as regards studies, this study as an example in Journal of Refractive Surgery, which compares by confocal microscopy the different technique of crosslinking, conventional, transepithelial, and accelerated corneal collagen crosslinking in the management for keratoconus, found that transepithelial crosslinking doesn't appear to alter corneal morphology, which means that it is not effective like EBoff crosslinking. Another study in Journal of Cataract and Refractive Surgery, they evaluate the effect of transepithelial collagen cross-linking in eyes with progressive keratoconus with short period of follow-up. They found that transepithelial cross-linking also is less effective than standard corneal collagen cross-linking. Also, in a study which compared transepithelial versus EBoff corneal collagen crosslinking for progressive keratoconus, they found that epithelium of crosslinking was significantly more effective than transepithelial crosslinking in halting the progression of keratoconus. This study published in Cornea 2015. So, another study about the efficacy and safety of transepithelial cross-linking versus standard cross-linking with epithelial removal. They found that also the standard cross-linking is more effective as effect in keratoconic eyes than transepithelial cross-linking. From previous studies, we can conclude that EBoff is very effective and with higher efficacy. However, EBon crosslinking is still in mind due to many complications which can occur with EBoff crosslinking due to epithelial removal, as delayed epithelial healing, corneal haze, infection, persistent epithelial defects. How to increase the efficacy of EBon crosslinking due to its benefits? This can be done by iontophoresis, enhanced riboflavin solutions, and crosslinking boosting with oxygen. Iontophoresis, we use electric current to increase the penetration of riboflavin to the corneal epithelium and increasing the cross-linking effect of it. Another method is enhanced riboflavin solution. What is meant by enhanced riboflavin solution is that riboflavin with special characters in its composition to increase its effect, especially in transepithelial cross-linking. These enhanced solutions increase the riboflavin penetration to the corneal epithelium. It is done by increasing riboflavin concentration or using substances increase epithelial disintegration like benzalkonium chloride. This study, published in Journal of Cataract and Refractive Surgery in 2012, evaluates the effect of transepithelial stromal riboflavin absorption with enhanced riboflavin solution by using spectrophotometry. It was an experimental study, and it found that administration of enhanced riboflavin with superficial epithelial scratches allowed sufficient riboflavin stromal absorption, which will be followed by a corneal ultraviolet ray application, and this will increase the effect of cross-linking of this transepithelial technique. Another study which studied the transepithelial corneal collagen cross-linking by enhanced riboflavin solution with vitamin E. They found that transepithelial collagen cross-linking using the riboflavin solution enhanced with vitamin E safely stopped keratoconus progression. This study is published in Cornea in 2016. Boosting cross-linking by the use of oxygen. In this transepithelial corneal collagen cross-linking, we use goggles supplied by high concentrations of oxygen. They found that the presence of oxygen during the process of corneal collagen cross-linking increases the efficacy of corneal collagen cross-linking. This study, published in International Ophthalmology Journal in 2018, they studied the transepithelial accelerated corneal collagen cross-linking with higher oxygen availability for keratoconus, and they studied the effect about 1 year. They found that transepithelial accelerated corneal collagen cross-linking in the presence of higher oxygen concentration partially prevented disease progression. This gives a promising result that we can use this technique to increase the efficacy of transepithelial accelerated corneal collagen cross-linking. Customized cross-linking, it is another issue in which we can customize the effect of corneal collagen cross-linking. The main aim of customized corneal collagen cross-linking to reshape conventional cross-linking. This achieves the effect by uniformly stiffening the central 9 mm of the anterior stroma. Customization pattern will allow surgeons to focally stiffen the weakest regions of the cornea rather than conventional approach, which uniformly stiffening the entire central cornea. Here we select the site we want to cross-link, not uniformly cross-linking all the cornea. This picture shows the different beams profile of UVA. These ring beams with different intensity according to the site, axial and tangential, while here it is sectoral axial map showing that we select certain sites and leave the other sites and not exposing it to UVA. Here that we apply the same intensity of UVA to all the corneal tissue. This by the using of OCT tomography and topography, we can cross-linking the needed sites like the cone, like the weakest point, and leaving the normal size and not exposing them to higher doses of UVA, which this is considered selective technique for corneal collagen cross-linking. Another technique which is called photorefractive intrastromal corneal collagen cross-linking, which is called PIXL. The device delivers specific light patterns to the cornea based in patient's topographic data used for refractive purposes. This means that we apply a certain UVA pattern to a certain meridian or a certain area of the cornea to produce a refracting effect by inducing flattening in this ablated area by UVA. This is considered a new era of corneal collagen cross-linking, like cross-linking 2 by Avido. I have no financial interest. Another topic is cross-linking at slit lamp. Here, the cross-linking can be done on outpatient clinic by using a device which is called CI device, mainly proposed for treatment of corneal infections at slit lamp. This device can be fixed to slit lamp and use multiple intensities 3, 9, 18, 30 milliwatt for different intensities for treatment of corneal infections. This device uses sterile cap to avoid transmission of infection to different patients, and this device also has optimized irradiation profile to specifically increase ablation UVA exposure to certain sites and compensate for thickening increase from the center to the periphery. Corneal collagen cross-linking in thin cornea. One of the limitations in corneal collagen cross-linking is the corneal thickness or the thinnest corneal chemistry. A minimum depixelized corneal thickness of 400 micron is recommended to avoid potential irradiation damage to the corneal endothelium. The modified cross-linking protocols in advanced keratoconus stromal thickness is often lower than 400 micron in advanced cases, which limits the application of corneal collagen cross-linking in this category. So, modified cross-linking protocols is needed in these cases. The solutions in these cases by decreasing power, increasing corneal thickness, decreasing time exposure, increasing riboflavin concentration. The modified cross-linking protocols for thin cornea by using hypoosmolar riboflavin solution, which increases the corneal thickness, transepithelial collagen cross-linking by avoiding to remove the epithelium, custom epithelial debridement techniques by epithelial removal only done at the needed site to be ablated, and the last technique to use contact lens assisted corneal collagen cross-linking. Another topic is photoactivated riboflavin cross-linking for infectious keratitis. The main aim here is to avoid to use antibiotics in these cases. Antimicrobial resistance. All of us know that antimicrobial resistance become a great problem to all of the world. This graph shows that by 2050, the WHO expects that more people will die due to antibiotic resistance than that due to cancer and diabetes combined. So, PAC cross-linking is a hope to kill bacteria irrespective of their antibiotic resistance. Another important issue here is that infectious keratitis is considered as a silent epidemic due to antibiotic resistance. Most of them are mixed infections, high costs, about 6 to 8 million new cases per year, and it faces many doctors of ophthalmologists. It is less common in developed countries, however, it is caused in developed countries by contact lens wearing, while in developing countries it is more common mainly due to injury due to blunt trauma. PAC cross-linking, it kills both bacteria and fungi, reduce diagnostic and therapeutic dilemma of antibiotic treatment, and it is considered as alternative to antibiotics. Effects of PAC cross-linking in infective keratitis in the cornea: it is increasing the biomechanical strength of the cornea. Also, it stabilizes and increases response of the cornea to the digestive enzymes of the pathogens. Effect of PAC cross-link in infective keratitis. In microorganism, interaction of the chromophore riboflavin with the nucleic acid of the pathogen and inhibition of its replication. Also, damage to the pathogen cell walls caused by massive amounts of reactive oxygen species. This study in Journal of Refractive Surgery published in 2014, it studied the effect of accelerated photoactivated chromo 4 for a case of atypical fungal keratitis in one patient. They found they can be used as a first line and sole treatment of this case and give a promising results. Another study published in Ophthalmology 2014, they studied the effect of PAC cross-linking for treatment of advanced infectious keratitis with corneal lentic. They found that they may be effective as an adjuvant therapy in management of severe infectious keratitis with melting. But evidence-based research is very important to judge the efficacy of this technique. In this study, in American Journal of Ophthalmology published in 2016, they studied the effect of PAC for treatment of moderate to severe infectious keratitis as an adjuvant therapy. They used two groups of patients, group treated with the usual treatment with PAC cross-linking and standard treatment alone. They found that treatment combined with PAC cross-linking didn't provide any advantageous effect over the standard treatment, which is disappointing result. My experience, I have a case, I want to share my experience in this case with you, of a patient with a 4-year-old boy with infected corneal ulcer with severe AC reaction due to trauma. Mostly blunt traumas. The patient received topical fortified eye drops and topical antifungal voriconazole but without response. The culture result, it shows that it is a fungal infection, but however it doesn't responding to any topical antibody treatment. The decision was to do PAC cross-linking as a last option. I do PAC cross-linking for this patient, and unfortunately the results was no improvement. Disappointment was great to me as my expectation was high, but the reality and the result was very disappointing to me. Conclusion: theoretically, PAC cross-linking is effective in treatment of infectious keratitis but need further evidence-based research. Another issue is pediatric corneal collagen cross-linking. Very important in pediatric corneal collagen cross-linking, when you start to treat pediatric keratoconus, you should know the following data. That keratoconus progression is most frequent in younger age, less than 18 years. Risk of acute keratoconus development very high, more significant and faster refractive and pigmentic worsening in young patients should be expected, and about 25% progression with cross-linking occurred in these cases. So all of these data should be in mind before treating this patient. Also, pediatric comorbidities, most of these cases suffering from ocular chronic allergy, vernal keratoconjunctivitis with continuous eye rubbing. So the progression liability is very high. Advices in treatment of pediatric corneal collagen cross-linking: 1. Don't wait for progression. Once diagnosed, must be cross-linking. All of us know that we should find a documented progression to start cross-link. Here, once diagnosed, must be cross-linked. Hit hard. Transepithelial cross-linking has no rule in this group of patients. Only standard epithelium of cross-linking is recommended in pediatric eyes. However, transepithelial cross-linking can be considered in thin cornea. Also, due to epithelial removal, take care of endothelium injury by UVA and also strict follow-up to avoid liability for infection. Also, after doing corneal collagen cross-linking, frequent screening for these patients should be done due to about 25% of cases show progression with cross-linking. Also, ocular allergy in these patients is very common, so you should tell your patients that no eye rubbing is needed, and also Don't do cross-linking in a case of active allergy, active VKC, and the patient should be treated well before starting to do cross-linking. As a summary of my presentation, what you need to know. Home message. EBon corneal collagen cross-linking is less effective than EBoff corneal collagen cross-linking, but however, the latter has more complication. Trials have been made to increase the efficacy of EBon cross-linking by enhanced riboflavin solutions, oxygen boosting during transepithelial corneal collagen cross-linking, and by iontophoresis. Customized UVA illumination patterns will allow surgeons to focally stiffen the weakest region of the cornea and not apply all UVA to all corneal tissue uniformly. Theoretically, PAC cross-linking is effective in infective keratitis but need further evidence-based research. Lastly, pediatric corneal collagen cross-linking treatment should be aggressive. Don't wait for progression, and frequent screening is mandatory. Thank you for your listening to my presentation, and I hope you find it beneficial to all of you. And lastly, I want to thank Dr. Imad and Dr. Miguel to let me introduce my presentation to all of you, and thank you very much.